Patient perspective on rare disease during a pandemic. I have no disclosures. By the end of this talk, I hope that we'll all be able to comprehend the perspective of a patient with rare disease in the midst of a global pandemic, extrapolate the choices faced by a rare disease patient in balancing pandemic risk mitigation versus continuing regular care, evaluate the importance of communication and the type of communication between a rare disease patient and their healthcare providers in decision making with the backdrop of altered societal behaviors. And lastly, to understand the relationship between speed of progress and preparation in daily decisions made within the rare disease ecosystem. Quick intro on me is Ryan Colburn. I'm 36 years old, born and raised in Los Angeles. I was diagnosed with Pompe in 2015, although with hindsight, I've been symptomatic since early childhood. As far as the things that I'm interested in and how I spend my time, I work full-time for a company that does space stuff. And my professional experience undoubtedly colors my view of the rare disease world and how to navigate it. In addition to that, I have a property in Los Angeles and I enjoy doing projects around the house, as well as spending as much time as I can, an increasing amount of time doing this rare disease stuff because, yeah, it's too much fun and there's too much opportunity to not put energy into it. And lastly, if I have any time left over, I'm a fan of sports. Hockey, my favorite, but I'll talk anything. As a quick level set, for context, I have Pompe disease and I receive ERT every 2 weeks as a part of a clinical trial. I have continued treatment throughout the COVID-19 pandemic. There are folks in the Pompe community who have interrupted treatment, some by their choice and some without choice. I've attempted to consider and provide perspective on a bigger picture, but it's undoubtedly biased towards my own experiences. For example, my own life experiences, biweekly ERT treatment concept, and challenges associated with Pompe. Relative to the pandemic, it also seems relevant to share that I lost my uncle, who was a father figure to me, on January 1st, 2014, to complications from H1N1, 4.5 years after that pandemic peaked. So I do have a little bit of personal insight into the durability of a pandemic. And lastly, you may have exposure to Pompe or any other number of rare diseases, and I encourage you to reflect on the concepts we're going to cover today as related or contrasted to the folks that you work with. So on to the pandemic part. I want to start out with something to consider. Some of the measures taken to minimize the probability of transmission of COVID-19, such as social distancing, extreme isolation, rigorous wipe down and disinfecting protocols, masks, etc., are daily experiences for some with rare diseases. We don't often get the chance to walk a mile or 4 months in other people's shoes, but this is a glimpse into a small part of it. And that seems like something worthwhile to spend a moment of thought with. When I'm faced with any challenge, I start out with trying to simplify it, to bring it into a range of understanding where I'm comfortable making a decision. So with respect to my disease, there's a near certainty probability value, almost 1, that my rare disease will decrease my health over time. When it comes to the pandemic, to specifically COVID-19, this means that there's a small possibility, a probability value much less than 1, that I'll get COVID-19. And now that probability value changes as a cumulative figure over time, but it also decreases with effective protocol and procedures in place to minimize transition. So on balance, it still is a significantly less than 1 probability value. And even if I did get it, it's only a possibility, still a probability less than 1, that COVID-19 will meaningfully decrease my health. So it's this balance, this equation that we're looking at with each decision that we make. One thing before we leave this slide is to remember that multi-factor probability is multiplicative. So if I had a 1% chance of getting COVID-19 and a 10% chance of meaningful decrease to my health, that would mean that I have a 0.1% chance of decrease to my health. So from this, we can have 2 general conclusions. One is the go forward conclusion, which is something like, I'm willing to take the risk of getting COVID-19 in order to minimize the certainty of my disease progressing. there also seems to be reasonable steps that I can take to minimize the likelihood of transmission. There's an alternate conclusion, which is the pause conclusion, which is something like, I know my disease, it's familiar, and I have an idea of what the progression looks like. However, there's so much uncertainty around COVID-19 that I'm not willing to accept any further risk of ill health or the possibility of death. What is the right choice here, and who makes that call? I'd like to introduce an excerpt from Squirmy and Grub's YouTube channel to give you a real world example of somebody faced with this decision. A person with SMA and his experience with this decision.
Hello, everyone.
Hello.
I know that we usually begin our videos with some kind of ridiculous joke, but today we have bad news.
About 2 days ago, we were contacted by the hospital that is supposed to do Shane's Spinraza injection, the new one. They told us that they have indefinitely postponed Spinraza injections due to the virus.
And we understand that. Like, I appreciate the precaution, but what that means is I don't know when I'm going to get my next injection. And I'm already 3 weeks behind. I'm feeling weaker by the day. It's just a frustrating situation all around, and I don't really know what to do.
So I think we see here that Shane did not have a choice in his care. And so Shane's one of the people whose health will be worse as a result of COVID-19, even if he does not get it. So what I propose is that if it's your life, it's your choice. These decisions are not easy, but when it's my life and livelihood on the line, then I want it to be my call. And I extend that logic to each of us in each of the roles that we have in this pandemic. I will add that I think patients are naturally emotional decision makers, and doctors must not be. So a little bit more about the critical role that doctors have to play in helping this decision process is that we need decision makers who understand the data and understand the risks and probabilities to help educate patients as much as possible so that we can make an informed decision. But again, I'll reiterate that I still think it needs to be the person whose livelihood is at risk who's making that final decision. So the next thing I wanted to do is just sort of think about a patient profile 3 different ways. I think for the most part, at least it's true for me, that my mind jumps to this middle segment of patients on treatment when looking at the topic of this discussion. And so that includes people that are on standard of care therapeutics and explore experimental drugs and trials, but it also includes people who have lifestyle adaptations, for example, a wheelchair that needs maintenance or any other adaptive equipment around the home or the work life that is also suffering and they can't get service, which really decreases their livelihood and health. So that's one category, but there's 2 other categories that also are affected by the pandemic and how we've responded to the pandemic. That's those who have yet to be diagnosed. And that's those folks who do or do not have symptoms yet, and who maybe have started to try to find a diagnosis, and even extending into those who are yet to be born, but will be born with a rare disease and require treatment. The next category is folks waiting on a future treatment. And that might be people for whom they have their diagnosis and a treatment exists, but they do not yet have access to it. Either just because of time or insurance company or availability in their region or country. People who are waiting and urgently waiting for treatments that are currently in an active pipeline, and then philosophically inclusive of anything that's in development or a theoretical stage, and just recognition of a continuum of progress with respect to future treatments. So I want to look at the cumulative effect of delays here to try to help drive this home. So we'll look at a typical example here on a timeline, so it's tangible. But again, this is just an example case. So a 3-month shutdown is a much greater than 3-month delay. And so what we see here in this difficult to read chart is that we have across the x-axis, across the going left to right, an increasing amount of time. In here, I've shown it as weeks. And in the first row, we show a normal schedule, a normal pace of progress, where we have an incremental milestone every 1 month. And so in this case, for the sake of the example, let's say that is a doctor's appointment trying to find treatment, and that we need to reach that magical number of 10 incremental milestones to achieve a diagnosis and then be able to discuss treatment. So in the nominal case where there's not these kinds of delays, if you're seeing your doctor or specialist are doing lab tests every month, and you get to 10 visits, 10 touch points at 36 weeks, and then you have your diagnosis and you can move forward. This is probably an accelerated, ambitious example. It actually takes much longer. In my case, it was well over 1.5 years, but just for the sake of a conservative example. When we add in the effect of a reduced throughput, so let's say with partial shutdowns and decreased capacity, people, reduce workforces, these kinds of things. Now that same product that took 4 months to work through, 4 weeks to work through, now takes 6 weeks. So the effect of that is now that we've reached our magical 10 element milestone 50% longer. It took us 50% longer to get there. So already a pretty significant increase in time. Certainly more than that 3 month equals 3 month scenario. When we add that 3 months delay plus the reduced throughput, it's the same exact timeline except shifted back by 12 weeks. So now we're at an 83% increase in time to achieve the milestone. And then in the last one we'll go to here, and as far as compounding effects of delays, we have the 3 month delay plus the backlog created during that 3 months, plus the reduced throughput to work through the backlog and also to go to the actual work. So we have our 3 month delay, we have our 4.5 months to get through 3 months of backlog, and then we have our 6 week interval for achieving sub milestones. And that's an 133% increase in the total time. So we're certainly more than doubling the effect of the shutdown in terms of the time that we lose in progress. So this example, as we went through it, applies to doctor's visits for those who are yet to be diagnosed, but it also applies to folks that are just doing research and data collection and doing analysis and write-ups for publishing. And really projects of any kind, whether they're basic or bench science, translational research, or trials, or even preparation for trials. And this is really a conservative example of how time can really get delayed when you allow it to. So this is over idealized. On top of all this, there's the stress of going back to work in an environment that you're uncertain in because you don't understand the data about how transmission really happens. So that decreases productivity. You also have suppliers and a supply chain that you're dependent on who is going through this same sort of cycle. So it really can be devastating to the progress and momentum in a rare disease community, or really in any community. So when we look at this a little bit more sort of big picture wise, what are the impacts of delays for a rare disease ecosystem? For the individual, if you're at the point of experiencing symptoms enough to seek diagnosis, progression is already meaningful. Delays in treatment is months or years of progression that you cannot currently, with most treatments, undo. And in many cases, it may not be as much about the progression that actually happens during those months or years of delay, but that the rate of progression changes as you progress. So time really, again, it's nonlinear in terms of the penalty that we take for pausing progress. Taking a bigger picture on this and impact on lives, we have a basic S-curve here showing the development and accumulation of knowledge on a topic over time. So on the left side, we start out with relatively little knowledge, and our ability to grow in that knowledge is also quite slow because we really just don't know enough to put the pieces of the puzzle together into a picture that makes sense. So it takes a long time to make a little bit of progress. As we make that progress and build on it, we're able to make progress much faster, and we experience a period of increased rate of knowledge acquisition, because we know enough basic pieces to put together that we can kind of fill in the rest of the pieces of the puzzle. And eventually we reach a point where we have some amount of saturation on that topic, and the rate at which we develop and acquire new knowledge slows down. So that's how we look at knowledge. But then I also invited a bunch of my little buddies here to plot on that same chart versus time, which is on the x-axis, to show that while all that's happening, people's lives are affected. So in this case, we have my little gray friends that represent folks of nominal health, and with each time period that goes on, we have a steady amount of people joining the ecosystem, joining the population, because they're diagnosed. During that same thing, as we move left to right in time, we have an increasing number of people experiencing declined health because their health can't improve until we reach a minimum saturation of knowledge, and then action upon that knowledge. And then even people progressing into a significant state of significantly declined health. So this is just to illustrate, and also, again, bring the point home that time is not independent of people's lives that we're trying to help. They are very dependent, and we need to treat them as such. Moving over to, so that's acquisition of knowledge. Moving over to the right side of the chart, we look at how we apply that knowledge towards technologies that help to improve a situation. So looking at this over time, we have we've gained enough knowledge to try to implement a technology that helps us to improve the state of the challenge that we're facing. And at a certain point, we have started to saturate the performance of that technology, and we have a phase jump into an alternate technology that works well. So in the Pompeii example here, this first curve at the bottom may be an enzyme replacement therapy treatment concept. And the second one might be we're jumping into a gene therapy concept. And then we have to see what comes next. So I invited my same friends back again, but this time they don't represent an individual state of declining health. They represent a population characteristic of overall health. So as we start out, we were just diagnosed, but then with the first generation type of treatments, we're able to help some people, but not fully, to maintain and keep a full, a nominal health state or a minimal decline in health state. But we still need to strive for more, and we really want to get to the point where nobody is experiencing a declined health state because of their rare disease. That's when we've really done a great job. And so that's going to take many iterations and multiple technology jumps to get there along the way. We're still very early in that process. So again, time will run away from us very quickly if we don't have this sense of urgency. So as we're wrapping up here, pandemics happen. They've happened before, they'll happen again. So how do we fortify? How do we respond to them better the next time? And as I mentioned just a minute ago, I think urgency is the most important thing, is develop a sense of urgency. And that's not to say that we want to have panic. In fact, it is specifically not panic. But we need to recognize that any delays in our progress are more punitive than the duration of the delay itself. And folks with rare diseases or who are dependent on progress, our disease is progressing even if the progress on treating it is not. So we are disproportionately burdened by these delays. And this type of thinking zooms in and out, right? So it works on a multi-month, multi-year project, and it also works on a minute and hour management of our activities. To truly respond and fortify is we need to have to work with a sense of urgency, so that we're minimizing the amount of delays and the punitive effects of those delays that we have in progress. And the best opportunity to protect progress and speed is outside of the pressure environment, in fact. So we really need to start working on it now to be in a better position for the next one. So whether you're doing research or patient care, all of us are relying on information, and the speed of that information is directly related to progress. And that information might be back and forth between a patient, it might be side to side between researchers and collaborators, and it might be also within regulatory environments, sharing information and those sort of things. The next part of it is simplifying everything, and details matter. So we need to strive for manufacturing simplicity, including simplicity in our supply chain, administration, intervention, deployment of a treatment modality. We need to get simpler in there, and then also logistical simplicity. So having robust storage, shelf life, pot life, etc. All of these things help to reduce the number of people that are involved in terms of getting treatment to a patient that can benefit from it. And the less number of people that are involved, the less penalty that we have when those people are choosing to focus on their health or their families, which is their right to do so. And we want to really attack this rare disease challenge with an attitude that we're going to challenge any system that seems fragile or slow. We're going to ask questions when things don't make sense, or when they seem to take a lot longer than the actual work. So for a lab test that we know takes an hour to actually run this, do the science part, we're not going to accept a 2-month turnaround period, or 2 months to get back to the patient with the results on those. So challenge anything that seems slow and unnecessarily slow. And so you can push back on this work as a researcher, as a consultant, as a doctor, on a trial site. If you're setting up a trial site, challenge your trial sponsor to say, why are we doing this? Does it make our data better? Does it make our ability to help people better? Versus does it slow us down, and is it bureaucratic? To put something else in perspective with respect to urgency, with a 1 in 10 estimate of people in the US having a rare disease, that means we have 33 million people in the US with a rare disease. That's 2 orders of magnitude higher than the total people with COVID-19. And that's not to say that we should not respond to COVID-19 in a serious and meaningful way, but it is to challenge us to act with the same urgency as we look at rare diseases and seeing the opportunity in front of us. With that, if you'd like to receive continuing education credit for this activity, please visit the website shown. Thank you, and I look forward to answering any questions in the Q&A session.